inviting me to present my work. Okay, so I'm going to be talking about socioeconomic disparities in mortality in the US and how they have changed over the past 40 years, including the recent pandemic. So, okay, that's not working. Oh, it worked like 5 minutes ago, of course. Oh, what did you do?
I just went back.
Okay, good. Now it works. Okay, so why do we care about socioeconomic disparities in mortality? Well, there are multiple reasons, which are both ethical and scientific. So for one thing, it seems really unfair that some people have much shorter lives than others within the same countries. In fact, eliminating health disparities is one of the priorities of the US government. It's an overarching goal of the, I think it's called Healthy People 2030 program. Looking into variations in mortality also can help us figure out what the upper bound of what's possible today in terms of how long people can live in a specific area. And so it demonstrates potential for mortality improvement within a specific population. It helps us, as all comparisons, it helps us identify the primary drivers of health outcomes and mortality in particular. For instance, it helps us understand how socioeconomic factors can shape health behavior. So there are many reasons why we care about that. And there are some reasons which are specific to the US, and I'll get to that later. Oops, sorry, so that. Okay, so there is a huge amount of work that's been done in this area, and much of this work is based on analysis of individual level records. These analyses rely either on vital statistics data, for instance, the work by Sassoon or Case and Deaton, which you're probably very familiar with. Some are based on survey data linked to death certificates through the National Death Index. And there are other kind of linkage studies like the study by Chetty, which I think has been presented in some seminar here, linking tax records with Social Security Administration data. This type of data is extremely useful. It's showed a lot of very interesting results. For instance, the work on disparities by education level showed that within the US, the difference in life expectancy at birth reaches up to, depending how it's measured, between 10 to 15 years between people who have not completed high school and college graduates. And there are a lot of such findings from these studies. But they also have important limitations. So for instance, the studies that use vital statistics are very poor in terms of the kind of indicators they use to differentiate between people. So on the death certificate, the only socioeconomic variable that's available is education, and it's missing for a lot of the respondents. For the survey linkage to the National Death Index, there are long processing times because it's pretty complex. This is done only every few years. So we don't have data in real time or for recent period. There are also the issues of the lag between the time when socioeconomic information is collected and the time when people die. There is a problematic treatment of children since they haven't gone through education and they don't own an income, so we can use parental information, but that comes with its own problems. And then the surveys are limited to non-institutionalized populations. So everyone in nursing homes or long-term care facilities who have higher mortality risk than the average population is excluded from this kind of studies. In general, studies relying on linkage of administrative information are very expensive in both time and resources. And then more generally, across all of these type of studies, there are issues of changing composition and increasing selection over time. So for instance, for education, people who don't have, who dropped off of high school make up a very different group today than they did 30 years ago. And so comparisons are difficult, or interpretation of the differences we observe are complicated. And then there are issues of reverse causality when you look at income and health and then mortality. So there is a second string of studies which are based on aggregate level analysis. So the idea from this kind of studies is that you group individuals based on some set of characteristics, and then you look at mortality patterns for each of the different groups you have identified. And this has become more and more common in terms of work with studies by Curry and Schwant and Irma Ilo and her colleagues, and then the people at the Global Burden of Disease, Sadi and Dwyer Lindgren, and Murray. They've done a lot of these kind of studies, and they've showed that these studies actually have a lot of value. Usually they're based on the construction of composite indices to determine these different groups of people, sometimes called deprivation indices. There is a long history in Europe using this kind of approach, especially in the UK, where Townsend in the 1970s was one of the first person to develop this. And the specific reason why he developed these deprivation indices for the UK was to help the government allocate resources for health in a more evidence-based way. There are multiple advantages to looking at area level instead of individual level data. So for one of them is that there are lots of information. There is no limitation in the kind of information you can collect on individual or contextual characteristics of the areas you take into account or the group you take into account. There are no issues of direct linkage since you proceed in two different steps. One step is to construct your composite index using one set of data, and then once you have the proof, you can use vital statistics data to compute your mortality indicators for the different groups. And there are also fewer of the methodological issues I raised earlier, such as reverse causality or issues about the classification on individuals based on age and so on. There are limitations, and I will get back to that later on in my presentation. But I also want to emphasize that these two approaches are not exclusive of each other. And in fact, people are trying to combine them because these previous studies have showed that both individual level characteristics and contextual factors combine to shape people's health and mortality risks.
Can you say something about life course period cohort, or is that? It seems like when you're looking at individually linked data, you're looking at if you're looking at an individual characteristic in the past, you know it's that person's individual characteristic. Whereas in the case of geography, you're looking at contemporary characteristics of the place and contemporary characteristics of mortality, but whether the people were experiencing that place or not earlier in life is not clear. Or yeah.
Right. So I actually talk about that later on in the presentation. But there are different angles, different strategies that can be followed depending on the specific question one is asking. So in this particular talk, I'm going to be following that second string of analysis, looking at area levels, so geographic-based analysis. And the four questions I'm trying to answer is, what was the socioeconomic gradient in mortality before COVID? Which age groups and cause of death most contributed to the socioeconomic disparities in mortality, though I may not have much time for this part. Whether socioeconomic disparities in mortality explain the US disadvantage in life expectancy, and I will get back to that again to explain more of the context, and how has COVID affected these previous patterns. Okay, so more specifically, the approach I'm following for this work is based on the construction of life table series, so all of the life table functions. They are period life table, not cohort life tables. for each calendar year between 1982, which is the first year when we have the data to do that kind of calculation, and 2021, which is the last data point that's available. For all US counties, the 3,140 something US counties, which are based and which are grouped into 10 categories based on their population level socioeconomic characteristics. So I'm going to explain in more detail on that. So the data I used, so for the socioeconomic variables, so to group the counties into homogeneous groups, I used the 2000 census. I've also tried to, so there are two different possibilities. One is to fix the country classification, and this is what I'm going to present today. So I fixed the country classification, the county classification on the data from the 2000 census. But it's also possible to reclassify the counties for each data point available. So all the census, so what I tried is to use the census from 1980, 90, 2000, 2010, and then the American Community Surveys for starting in 2007 all the way to the end. One of the problems of doing that, changing the classification, is that interpretations are more difficult because the counties move, so the people do not belong to the same groups from one year to another. And we can discuss that, but basically the results, I was very surprised to see that the results are very similar whether we use the fixed classification or variable classification. And then for the mortality information, I use the individual death records from the NCHS for every year, every calendar year, 1980 to 2021, with information on sex, single age at death, underlying cause, and county and state of residence. And then for the denominators of the rates, I use the July 1st estimates from the Census Bureau, which are also provided by county and states. So I proceed in 3 steps, basically. The first step is to use the 2000 census data to create a single socioeconomic score for each county. And I explain how I do that. So each county gets a score. I then rank the counties based on their score from most deprived to least deprived. And I group them into 10 categories after weighting by the population. So each of the groups represent 10%, or I don't cut counties, so about 10% of the population. And then for each of these 10 deciles, I calculate specific life tables using the data I described and the methods of the human mortality database. And I want to thank Celeste here and Carl, who is online, for their help to do that.
Is the interpretation that if we think of effects, of causal effects here, is the interpretation that living in a place in this decile causes you to have a certain mortality outcome, or is that the level of the analysis?
So, well, we need to discuss that because that's something that I mentioned at the end, that there is something called the ecological fallacy. I don't know if you know that. You probably know about this discussion, and the fallacy is that you assign to individuals in a group the characteristics of the groups, and that's a mistake. It creates bias. But we can revisit that because that's part of the larger.
But is that the goal of the analysis, to find out what it's like to live in a place, or is the goal to actually find out what the effect of individual characteristics are and just do that indirectly?
It's the effect of living in a place.
It's
with the limitation that.
Yeah. Thank you.
Okay, so the socioeconomic variables I use to create my county score are, so there are 2 variables that have to do with education, a variable on occupation and unemployment, 3 variables that have to do with income, so the median household income, which is actually which is mitigated by the fact that I take housing costs into account, because the same income doesn't give you the same living standards in San Francisco Bay Area and in the middle of Nebraska. Some measure of income inequality, some measure of poverty, and then median home value both for owners and for renters, and then some indicators of housing equipment. And all of these variables were, so this way of constructing the socioeconomic index score was borrowed from Singh, who published a bunch of paper in the early 2000s using this approach. And he was looking at the 1970s and 80s, and I wanted to continue the trend to see what was happening. But I made some marginal changes to his method, but I wanted to compare my results with his to make sure I was doing things properly. You can use a different set of variables. I also tried that. Again, doesn't make a lot of difference. So the way the socioeconomic deciles are constructed is first, so I extract the information from the census for each county. And then I run a principal component analysis, and I use the correlation on the first component, and I use that as the weight for the variables for each county. So I multiply that by the variable in each county. And then I add up all of the components to get my score, and I actually standardize the score, but detail is not important. Then I rank the counties on their score. And after weighting by the population size of each county, I split into 10 groups. So from now on, I'm going to be talking about socioeconomic deciles, which are these 10 groups of counties based on their socioeconomic characteristics, the ones I've described. So this is a plot that shows you, so here you have the socioeconomic index score that range from 0 to 200 basically, and then each line here corresponds to a decile. So the first decile is the most deprived always, and the 10th decile is the least deprived. So what you can see is that the most deprived group is made of a lot of small counties, and there are mature counties actually making up the middle deciles. Los Angeles, which has, so each of these groups is about 10% population, so about 35 million people. LA, which is more than 10 million people, represent a third of the group to which it belongs. It's somewhere in here. Cooks County is also a huge county near Chicago. It's also somewhere here in the middle. So you can see the spread here at the extreme is much larger than here in the middle. So you will see in that there is some overlap for the mortality risk here in the middle groups. And here is a map of the distribution of the counties based on the deciles to which they belong. So again, one is the most deprived in red, and dark green, the least deprived, the most privileged in green. And you can see how there are lots of these small red counties in the southeast part of the country. And the green counties are mostly around the big metropolitan areas. Okay, so the first thing I'm showing you is what was the socioeconomic gradients based on this data before COVID, so between 1982 and 2019. So you can see different things here. So one of the things you can see is that, and that's pretty striking, how clear the socioeconomic gradient is, except for the middle deciles, and I explained why, which are overlapping, but they're basically stacked pretty neatly one on top of the other. The second thing that you can see is that the socioeconomic gradient has increased over time, and that's especially striking for women. So for men, the difference in life expectancy at birth between the two extreme deciles was reached 3.9 years in 1982, and it increased to 7.4 years. And then for women, it went from 1.6 years to 5.8 years, so a huge increase. And the last very interesting thing that you can see here for men, at least, is that after 2010, when at the, so mortality improved in the US until 2010 pretty linearly. And then in 2010, progress stopped. And in 2014, there was a turning point where mortality increased, life expectancy declined between 2014 and 17. But what's interesting here is you can see that the reversal, or at least the slowing down in progress, affected all deciles. So even the 10% Americans living, or the 20% living in the best of counties, experience a really strong slowing down of progress in life expectancy. So looking at which age groups are most affected by these trends. So this is the ratio of mortality. Oh, I forgot the date, but that's in 2019. So the last point of the graph I was showing just before, the ratio of the QX values in each of the deciles by age to the US average. And men are on the left and women on the right. And you can see that the ratios are highest for children and for working age adults. And then the decline as time goes on. And there's even something like a crossover at the very high ages. But there are discussions about data quality versus selection effect for these high ages. And I'm not going to concentrate on this for this talk. So you see here the age standardized death rates for these ages I was mentioning, 20 to 64. And you can see that the increase in the socioeconomic gradients, especially for women, is particularly marked at these ages. And the gradient itself is really strong. And what's even more striking is for women here, for the 20% women in the two most deprived groups, basically there was no improvement and even a deterioration throughout the periods between 1982 and 2019. So over 40-year period, there was no improvement in the probabilities of dying for women between the ages of 20 and 64, which is really tragic. Okay. Yeah.
The red line for the women equals the red line for the men. It's the same counties, is that right?
Yes, yes. Yeah, I didn't, yeah. If you look at the contribution, so the difference in life expectancy at birth, as I mentioned, in 2019 between the two extreme counties was 7.2 years for men and 5.8 years for women. If you look at the contribution of the age group to this difference, you have a slightly different pictures where most of the contributions are concentrated between 55 and 65, 70, because as demographers, you probably realize that a small or large difference in small rates will have less of an impact on life expectancy than a small difference in very big rates. So that's what's happening here. Okay. So the second point was what happened during COVID. So what you see here is added data. So it's the same graph I was showing before, except that here we have two additional points for 2020 and 2021. So what you can see is that there was a very steep decline in life expectancy at birth in both 2020 and 2021 for nearly every group in this analysis, except for the best or the least deprived group, the dark green. And the decline in life expectancy between 2019 and 2021, so over 2 years, ranged from 1.6 years for the top deciles to 4.2 years for the bottom decile for men, and then for women from 1 to 3.3. So as you can see, the gradient, the socioeconomic gradients, the difference in life expectancy between the extreme deciles is of course going to increase quite a lot by 2.5 years for both men and women. And so the difference in life expectancy, the gap in the length of life, increased to nearly 10 years for men, which is pretty big, considering the fact that there is a lot of heterogeneity within each of these groups. And then for women, it reached 8 years. I was really waiting for I was in the starting block for the 2022 data to be released so I could see what happened. Then, but apparently the states have decided that providing their data to the NCHS is not a priority. And so usually the data is released in December, but the CDC is struggling right now to get so they published a report in December, but based on preliminary data, and they're always waiting for the final data before they publish, before they give access to the individual records, and we still haven't seen those. So I can't tell you what's going to happen, but my guess is that the rebound is gonna spread to the other top deciles, and the decline is going to continue for the bottom deciles, but we'll see. So this is the same idea, but this time we're looking at the age standardized death rates, and the pattern is even more striking. You can see how the age standardized death rates for many of the deciles in 2019 was, I'm sorry, in 2021 was so much higher than in 1982. So this work was actually funded by the Society of Actuaries, and the actuaries wanted me to look at what would have happened without COVID. And the way they wanted me to do it was, they said, just remove the COVID death and then recalculate life expectancy or life tables. So first I had to explain that we have this special cause-related life table method where we assume that people who survive from COVID would have experienced the same mortality risks as the rest of the population, which is a discutable, or I wouldn't say discutable. Sorry? Debatable hypothesis. And then I explained to them that a lot of the excess mortality that we observed was not directly linked to the biological impact of COVID. So we talked for a while, and then I offered to do these 5 different, to look at these 5 different things. So the idea is that we're looking at excess mortality during COVID that's directly linked to COVID, and that's indirectly linked to COVID. But the issue is to find the right counterfactual. So when you say without COVID, what would have happened, you're implicitly comparing to some other normal situation, but how do you select that normal situation? That's complicated. So I offered to make these calculations using 5 different strategies. So the first one is just to compare 2021 to 2019, and then 2021 to 2020. And then to do the COVID-related life tables for 2021 using excluding only the death certificates where COVID was the underlying cause of death. And then a second strategy where I exclude COVID as a multiple cause. So the death certificates include 20 different possible lines for cause of death, and the medical examiner is supposed to report the initial cause, and then they can also mention other causes that were involved in the morbid process or contributed to the morbid process. So that's what we call the multiple cause of death. And then the last strategy was to project the risks for the period 2010 and compare the 2021 life tables with the life table constructed based on this projected risk for 2021. So these are the results. So each column corresponds to a different scenario, and then each line corresponds to a specific decile. So the first scenario, which is basically what you saw in the graphs I presented, was just a comparison of 2021 and 2019. And you can see that what I was saying, this is for men, it varies, the difference varies from 1.6 years to 4.2 years at the two extreme of the distribution, and it's fairly linear, increase with each new decile. You can see that the difference between 2020 and 2021 is less than half because there were more death in 2021 than in 2020, more excess death. And then these are the cause-related life tables. So this column, that's not very good. This column with COVID as the underlying cause of it, and this one as any cause, any mention. There is not much difference between 95% of death certificates which have a mention of COVID had COVID as the underlying cause. So only 4 or 5% had COVID as a contributing cause. So the difference is not much. It's also much smaller than looking at overall mortality, excess mortality, because well, there could be some problem of misclassification. So people who actually really died of the biological impact of COVID, but their death, the cause of death was misclassified. But there is also a huge amount of death that were excess death that were unrelated to COVID. And I'll get back to that. And then for women, we have a very similar pattern, except that again, one thing I forgot to mention is that when you look at predicted versus observed in 2019, the predicted is lower than you observed, and you would have, if mortality had been improving before COVID, you would expect larger values here. But because in the US we have these erratic trends in mortality with a stable 2010, 14, then mortality increase between 14 and 17, and then decline again in 18, 19. When you use these two projects, you get lower level of mortality in 2021 than in 2019. And so the values are smaller in the last column compared to the first column.
Could you just say another word about why you think there was a lot of excess death in non-COVID related causes during that year? And not the mechanism, but what the evidence for that is? Because I thought that there wasn't much evidence for that.
Well, I show the cause of the analysis in a minute.
Don't we know that there was this misreporting and misallocation of death is very geographically structured, so that in certain places they're much more likely to reclassify, and that's related to your deciles?
Yeah, but you'll see that's not the explanation. So this is for women, so very similar readings with smaller numbers, because women, excess mortality for women was lower than for men during the pandemic. This is the ratio of the risks of dying or the probabilities of dying in 2021 to 2019 for each decile. You can see that the peak, most of the excess was concentrated here among younger working age adults. There's nothing here at higher ages, which might surprise some of you, since we know that most of COVID death were directly caused by COVID were concentrated at higher ages. And this is in large part due to a small harvesting effect, where the friendless people who died of COVID at these very high ages would have died within that year anyway. Okay, I don't have much time left, but I want to show you two more things. So this is a decomposition of excess mortality as measured by the age standardized death rates for each decile by broad cause of death. So 2/3 is directly attributable to COVID. 2/3 of the excess is directly attributable to COVID. So everything that's above the line here shows a deterioration of mortality, so excess mortality, and everything below the line shows improvement in mortality. So for instance, here, this little thing here means that for the population in deciles 5, cancer actually continued to improve. Mortality from cancer continued to decline throughout this period. But what this shows you is that there is a large part of excess mortality, about a third, that's attributable to other causes than COVID. So some of that is cardiovascular disease, and there could be some misclassified COVID there. That's very possible. But another large part is external causes, and this affected mostly young adults. So the young working age adult, that the excess I showed is largely driven by this. And it's hard to believe that there would be misclassified COVID that would end up into external causes. So these are, for people not familiar with the term, these external causes are violent death, basically. And if you want, I have a bunch of graphs showing you for specific groups like drug poisoning, alcohol, suicide, and so on. I can show you what the trends were. Okay. And then I compare, so most of this is 2019 to 2020. That pattern is very similar when you compare it just to 2020 or to 2021. And then here, so it looks like there is less, but this is comparing 21 to 20. So it comes on top of the excess for 2020. You can see that in 2021, the only county that clearly did better than in 2020 were the best of counties.
Right, Magali, so with the drug deaths, is that an external cause or is that?
Yes, that's an external cause. Okay, and then the last thing I really wanted to show you is this shocking graph. So this is a comparison between each of these. So there is a lot of literature on the US disadvantage in mortality. The US is not doing as well as peer countries. And some of the discussion centered around the fact that the US is a very heterogeneous country. And so the idea is that, yeah, well, you can't really compare the US to other countries. It's so much bigger, and it's the population is so heterogeneous that, you know, some people are doing much better than Europeans, for instance, and others are doing worse, but that's, you know, the composition of the population has a big impact. So I did this work that was published in the Journal of Gerontology, where I showed that actually socioeconomic inequalities in mortality in the US do not explain the US disadvantage in mortality. And this is very, this confirms some work we have done in the past with John Wilmot in particular and Carl, showing that geographic inequalities also do not explain or explain very little of the US disadvantage in mortality. Because what you see here is these gray lines are the deciles, so that's the same graph as before. And then the black line is the US average. And then in red here, you have the average for 16 high-income countries that include most of Europe, but not Eastern European countries, which have a different, very different mortality patterns over time. It also includes Japan, which shows up here in blue because it's the top for life expectancy at birth. It includes Canada, New Zealand, Australia, and so on. The usual suspects. And what you can see here that's very disheartening is that even the best Americans in the top deciles are just barely, in 2019, before COVID, we're just doing barely as well as the average for all of these 16 countries, which also are some heterogeneity. And then for both, actually, it's even more striking for women. For women, the average for these peer countries was higher in life expectancy than for the best decile. But COVID has created this further gap, has increased the gap pretty considerably. Because you see here the last data point. So this is up to 2020. I didn't have enough, when I created the graph, I didn't have enough HMD countries. I'm using HMD for this. I didn't have 2021 data for enough countries to carry out the comparison. But what happened is in 2021, the average for these peer countries actually improved, and for the US, it continues going down. So the gap is even bigger. Okay, so I'm done. So COVID induced a major jump in mortality for all US deciles, for all socioeconomic deciles. There was an increase in the gradient within the US, an increase in the gap with other high-income countries. The deterioration was particularly severe when measured by risk of death for working age adults, and the effects were as much biological as social and behavioral, as indicated by the increase in external causes. And then I want to, so the next step, and that's part of the discussion on limitations. So as I said, I'm eager to look at future trends. I'm also interested in looking at, so one of the issues, and that brings me back to a question that Josh asked earlier. So people move, of course, and it's very possible that this deteriorated or this increase in the gradient in socioeconomic disparities is not due to the fact that any individual people has seen their health deteriorate, but that there's been increasing residential segregation. So people with poor health migrated to these worst off areas, and people in good health migrated to the good areas. So because of these composition effects, there was some change in the average, but not for any single individual. So I'm really interested to look at how people sort themselves. There is very contradictory literature on this topic. Earlier studies suggested that could be a concern, but there was a recent paper that suggests that actually people move to the same kind of areas that they come from. And so it doesn't have much of an impact. And then another thing I'm interested in is look within each of these groups at specific contrast between rural, urban counties, for instance, or biracial groups. I'm also interested in combining the individual level and aggregate level analysis. So using this as for the context, and then look at what happens when you look specifically at, so for instance, do Black people in or poor people in wealthy area experience the same kind of disadvantage as poor people in poor areas, this kind of thing. And then the last thing is to look at, so at the same level of socioeconomic deprivation, we have some diversity. So some counties are doing much better than others, so better than expected. So I'm interested in looking at these specific counties to figure out, is there something we can learn from that in terms of what works? Or was there some kind of policy or specific contextual characteristic that could explain the fact that these countries are doing better off? And can we use that to leverage better public health interventions? Okay, and then I just want to acknowledge funding, including by CEDA, and the help I got from people here at HMD, and then at INED and here.
Very, very interesting. I have a couple just quick points and then more general. One is just on the moving. Moving rates have gone down very quickly since '82. So whatever self-selection there is, the process is, I think rate of moving is almost cut in half in this 10-year period. It was very low to start with, but it's got cut in half. So it's a time moving thing. And another feature of the migration is how much of it is increasingly politically driven. And that creates another point I was going to raise, which is some of the research showing that COVID deaths increasingly correlate with politics. And the politics will correlate with your index. And the final thing I'll say is in the construction of this socioeconomic differentiation, you put education indicators together with material wealth indicators. And I think one exercise that might be done on the side is to separate those, because one of the things that seems to show up in the last couple of generations is that the coupling of income, high income and high education as determining lifestyle, for instance, that would include, health-related lifestyle, has been weakening, and that these two dimensions of income and education in terms of their consequences for people's behavior have become separate, increasingly separate, so that you might see a somewhat different pattern if counties are ranked by education and counties And you can think of, college communities in the Midwest, which are high proportion of population is highly educated but not making much money. So anyway, that's a
No,
possibility.
you're absolutely right. And I saw some of this literature. And actually the gradient is not so clear if you use only education or only income and wealth. And some literature has showed that in terms of education, it's clear that people with higher education have experienced improvement in mortality over time. But for people with low education, it really depends where they live. And so that was really interesting. And then your second question about polarization, political polarization, yeah, I've seen a lot of work in this respect. And that's another way we could look within each of these groups, what happens specifically to red versus blue counties or something like that. And I have a student, Denise Dukovnov, who is doing actually a dissertation on doing some spatial analysis, who looked at not red and blue counties, but on public health indicators of the kind of philosophy in terms of welfare and social services, which is very interesting. And your first point about migration would tend to strengthen my finding, meaning that migration would not be expected to have much of an impact anyway. Josh?
I was wondering the increase in inequality from 2000 to 2019 before the pandemic. Do you have an interpretation about the cause specific pattern of that? It's not just opioids, it's cardiovascular disease. Is it everything, or do we actually get a new story
Yes.
looking at your data?
So I did some work on that in the past. So the opioid epidemics explain the drop, the reversal between 2014 and 17. But it doesn't explain the slowdown throughout the period, which starts actually before.
I'm thinking of the
2010.
inequality.
Inequality, yeah, everything explains.
It's
Yeah.
everything. It's
Yeah,
cardiovascular
it's some
disease,
of everything,
cancer,
yes.
smoking,
Yeah.
everything.
Cardiovascular disease has a huge weight. The gradient is really large, but it's also the leading cause of death. So of course it's going to have a big impact, but everything contributes. Other disease at other ages, and infant mortality and older adults, and digestive disease. Metabolic disease is also a big one, with diabetes mellitus being clearly very socioeconomically related.
And then similarly with age, is most of what's happening in increased inequality below age 60? That's kind of the story we get. Or with your analysis, you can also look at the older ages. Do you see actually a big part of it is also happening at older ages?
Well, that's what I was showing in earlier graphs. That actually here. So at very high ages, you don't see much. But it's mostly above 85 or 90. So for older adults, 60 to 90, you see a gradient. But in terms of the ratio of the risk, you don't see much. But if you look at the contribution to life expectancy, then 65, 70 has a big weight.
If we go back to the slide where you show the summary measure at the life expectancy okay, here we see this widening.
Yes.
Is that?
The widening itself.
Yeah. Is this happening at all ages? Or I guess the conventional story that I would have is, oh no, this has to do with opioids and deaths of despair and things like that.
Yeah,
but maybe not.
So young adults, these working age adults are most of the explanation, but there is also an increasing gradient for other, not so much for infant mortality, I think.
At age 70, age 80.
Yeah,
Okay.
older ages as well. Maddie?
My question was also on this slide. So do you have any sense of why there's such a difference between men and women? Because the men, it is widening, but it looks much more parallel than the women, where there's such a dramatic difference between the upper and lower deciles.
Yes, so you have to be careful because the scales are not the same. You can see here the Y scale. For men, it goes to 700. For women, half that much. So if we use the same scale, it wouldn't look so dramatic for women. But in general, we know that the overall story about mortality in the US over the past 40 years has affected women more than men. So for women, the slowing down in progress started in the 1980s. For men, it's more concentrated over the past 10, 15 years, and the story is more, about opioid and reversal in cardiovascular mortality progress. And for women, it's been, Sure. So can you see if there are questions or not?
You can see that we have enough chat if you want. We have a couple people. I don't know if you want somebody to.
Why sometimes? Do you want to start from me? Here. Okay, I wonder why mortality dropped by a lot for the top deciles between 20 and 21. Well, both vaccines. What happened? That's a typical story in looking at mortality. What happens when there is some progress in medical knowledge or a new technology that helps to improve health, or a new understanding, like for smoking, for instance? What we see is that the first people to benefit are the best of people, the more educated, the wealthier people. And then there is a catch-up progressively, but there is a time when there is a huge divergence before it converges again, unless there is a new discovery. And that's what happened during COVID. Once people figured out you could just stay home and not get exposed, and you had the means to do that, you weren't working in one of these professions that were most exposed. And once you figured that the vaccines worked, you were the first to benefit from it. And these people were mostly in the top deciles. So I wonder why sometimes the ratios of mortality is used to measure the inequality sometimes. So I don't understand the question.
I think, is there a basis for using ratios of mortality rates versus life expectancy, or they're just wondering which measure?
Well, you want to use different indicators, because each indicator gives you a different angle, a different understanding of the phenomenon. So that's why I've showed life expectancy and contribution to life expectancy, and then a decomposition of the standardized death rates. Again, they show different things, and they give you a richer understanding of what's going on.
Is just a general question?
Relative measure of inequality versus absolute. So the problem with absolute measures of inequality when you look at a long time period is the problem of selection. That's what I was explaining at the very beginning. For instance, if you compare people who have a high school degree to people who are college educated, the population was very different in 1980 than it is in 2020, because of improvement in education. And so there's a selection down in terms of health into the least educated groups.
I think the question is more statistical, and it shows up in other kinds of studies of inequality. That is, for instance, if you're interested in black-white differences in income, you subtract one from the other and track that change, or you do the ratio of one to the other and track that change, and you get different answers.
Yes, that's true. Yeah.
So I think that's what the basis of that question.
Okay, so I have to wrap my mind about what implication that has on the work. Was there anything?
I think that was just a thing about sound.
I have a general question about the counties versus, because HMD started with countries, and then you guys did very impressive state database. And I could imagine one could do this kind of analysis with the states. You might not have 10 deciles, maybe you do quartiles or something like that. And now you have counties. Is there, besides just having more data points, is there something about the counties that adds a lot of dimensions to the kind of analysis you can do and richness, or is it just smaller, gives you more detail, or how does it work?
Well, it gives you more detail in a way, but it also limits the kind of thing you can do. You cannot do cause of death at the county level, basically. I mean, the GBD does it, the people at, the IHME, they do it, but I have a lot of suspicions about the way they do it. And especially, I mean, you can always do it, but then how do you interpret the results? So for instance, they're implementing these Bayesian models to estimate mortality by cause, but they use as prior, they use similar counties based on geographic location and socioeconomic characteristics. So you can't say anything about geographic difference or socioeconomic difference on this outcome because they are embedded in the model. there is a big endogenic issue. So that's one of the problems. But however, the work I was mentioning, looking at the best of counties within each of these groups, could be done based on that. But then, looking specifically at cause of death will be a problem. So it has to be done differently.
But I mean,
But the story will be the same. I mean, the work we did with Carl and John a few years back was looking at the county level data that we had gotten from HME, actually, ironically, and the story is about the same. So, but not as obvious, because a lot of this pattern has become even magnified over time.
I was just, oh, Jenna.
Oh, it was a question, Jenna?
Yeah. Hey, Magali, can you hear me?
Yes.
Okay, great. Yeah, I was just, to Josh's question, I think there's a whole group of people who argue that the county is a unit for political decision-making or for decision-making around policy that affects the welfare of people living there. So I'm sure you've encountered the County Health Rankings Project along the way. And I think at some point they built like a COVID atlas. So I was struck by your point at the end of trying to think about what do you learn from case studies of specific places where mortality is actually improving. And I think that's the logic that whole enterprise takes as well, which is, do county specific case studies tell us something about the political economy of life-saving?
Yeah, I absolutely agree with your point. It gives a richer picture of what's going on beyond looking at racial differences or socioeconomic differences. So taking really contextual factors into account, including political factors. I completely agree with you. And there is a little bit of, there's some developments in this area. I think it's Jennifer Montes who's doing a lot of work in this area. That's very, very interesting. Yeah.
I was just going to ask if there were specific, I was trying to look at this just this time and think about big policy changes like Obamacare. Do you see any, when you look at these trends, do you see any effect of any?
No, I think, from what I've read, so we don't have the data for before 1982, but a lot of this seems to happen around that time. And there was a lot of emphasis in the literature about the Reagan policies that created a lot of inequalities. So yeah, that seems to be the underlying driving factors, and then everything that happened since then in terms of inequalities. And all the work of Casey and Deaton showing that education is becoming increasingly important. Yeah, that's what I'm saying.
Great. Wonderful. Well, thank you so much. That was fascinating.